Good morning, everyone. We're going to start on time. We have a very busy schedule, and it's tremendous to have you here. I'm Tanis Cameron. I'm the chair for this International Tracheostomy Symposium, and it's really fantastic to have you here. It's been about 2.5 years' work with the Global Tracheostomy Collaborative, the Austin Health team, the Royal Children's team. And at the end of that, I can honestly say it is an inspired program that we've got for you. People have put a tremendous amount of effort into it. I'm going to make a couple of housekeeping comments. We are in room 105 and 106 of the first floor of the convention center. In the event that we need to evacuate, you would go out the front door, take a right, and another right. The escalator would have stopped, and you just take those stairs downstairs. A right and a right again gets you to the restrooms. Our staff are wearing a green lanyard. If there's anything they can do for you during the program or throughout the day, please make yourselves known to them. There is an ITS registration desk and a GTC information desk. Please use those two resources. The GTC folks will be at the registration desk or at their information desk. Hosting something like this is a tremendous privilege, and I just have to say that the energy is incredibly positive. All of you have had a real buzz about getting back to us and asking questions, and we know that's going to continue throughout the day. I think that's what I needed to cover, just to say hello, and it's my great pleasure to introduce Dr. Brendan Murphy, who's the Chief Executive Officer at Austin Health, to open our meeting.
Thank you very much, Tanis. So I heard just there that she's called TC to her friends, so I'm going to remember that. Good morning, everybody, and a warm welcome to everybody, to all the international visitors, all the local guests and delegates, and particularly patients and families. Welcome to the 2014 International Tracheostomy Symposium, and particularly the Australian kick-off of the Global Tracheostomy Collaborative. As Tanis said, my name's Brendan Murphy and I'm the CEO of Austin Health. For those who don't know Austin, a few of you in the room probably don't, we're a major academic health service here in Melbourne, and we're very proud, extremely proud, to have a strong tradition in tracheostomy care. This conference is jointly hosted partly by three great Austin teams: the TRAMS team, the Tracheostomy Review and Management Service, the VRSS, the Victorian Respiratory Support Service, and the intensive care team at Austin Health, together with our co-hosts, our great local partners at the Royal Children's Hospital, and of course, last but not least, the growing and really exciting initiative of the Global Tracheostomy Collaborative. We're particularly delighted that David Robertson is with us today. The leadership that he and his steering committee have provided worldwide have given birth to the collaborative and led to its increasing uptake to change the lives of so many people. Welcome to all those associated with the collaborative and to all of the 340 delegates and speakers from Australia and around the world, representing, I'm told, an amazing 90 institutions and 49 tracheostomy teams, including many very distinguished speakers about whom you'll hear much more later. As I mentioned earlier, we are very pleased to welcome this morning patients and families who, of course, are the reason for our existence and for whom have been at the very centre of the Global Tracheostomy Collaborative since its inception. I think it's a really exciting development. So many conferences now feature parts or whole conferences with consumers because it gives a particular meaning to our purpose. This morning's session will be dedicated to the Australian kick-off of the collaborative, following its launch in Boston and London earlier this year. We're very proud in Australia to be the third country to be officially launched. It's very clear that the collaborative is a major step forward in taking tracheostomy care to the next level. It has a very simple but very powerful message to partner with hospitals and providers around the world and to work together to improve the care, safety and quality of the life of every individual with a tracheostomy or laryngectomy. 40 hospitals across the world have now signed up, and from the outset it has had significant patient and family involvement. After the kick-off meeting this morning, The program this afternoon will move into the International Tracheostomy Symposium with a really exciting program and array of speakers addressing many topical issues in tracheostomy management. It promises to be a great day. Can I congratulate once again Tanis Cameron, the indefatigable TC, the conference chair and convener for her great organising committee for bringing together this exciting day, and once again thank our very many national and international visitors to Melbourne. I'm sure that today will surpass all of your expectations. Thank you, and once again, and welcome to Melbourne to the kick-off meeting and the symposium. And now I'd like to, for the sake of brevity, introduce the convener for the first session, the Deputy Director of Intensive Care at Austin Health, Dr. Stephen Warrilow. Thank you.
Thank you, Brendan. Welcome again, everyone, to the GTC Kick-off here in Melbourne. It's a packed and very exciting day, and I'll endeavour to steward you through it, keeping to time, but also allowing sufficient opportunity for a full and enthusiastic engagement, which we're all very much looking forward to. Firstly, I'd like to introduce David Robertson, who is actually very well known to many of you here today as a previously frequent visitor to Melbourne. David is an extraordinary example of leadership in the GTC and demonstrates, I think, brilliantly the nexus between an individual clinician providing excellence in care to an individual patient, but also having the vision to take what needs to happen in healthcare more broadly to patients beyond their individual sphere of influence to places that are far-flung and distant, including Melbourne. So David has provided a great example of this and will now explain to us and convey the real essence of why the GTC is so crucial, what it has to offer, and give an outline of what collaborations can offer to tracheostomy care more globally. David, thank you very much and welcome.
Thank you, Stephen. It's a tremendous privilege to be here. Thank you all for joining us. Some of you may just be starting, but I know many of you are quite far along the journey, and some of what we cover today may be old news, but I hope there'll be something valuable for everyone. The first thing I'd like to tell you about the collaborative, it's truly a global and a team effort. We have members from around the world. We share the work, we share the decision-making, we share the responsibility. I'll admit there have been a few times where it didn't feel completely equitable, and in particular, it's been noticeable on occasion that a disproportionate share of the leadership and the hard work was coming from what we might call the upper hemisphere. These are our upper hemispherians. And the great thing about, Stephen assured me this was the right map, is that correct? The great thing about having people like this is it makes those of us in the lower hemisphere look bad, and we don't want to look bad, so we have to work harder and better and elevate our game. And while we haven't caught up to these guys, they've certainly made us all better. Before I talk about GTC, I'd like to talk about TRAMS. You will hear from a handful of really outstanding tracheostomy programs around the world, and you're going to hear from a couple today. But what makes TRAMS really unique is the breadth of the program, from the ICU to the floor to the rehab hospital to the community and back again, the breadth of the networking within the hospital and the different services, the depth of the materials, the protocols, the educational materials that are available to be shared, and the outreach that TRAMS has already been doing with many of the tracheostomy teams here. If I were to say that TRAMS is the best program in the world, a couple of our subsequent speakers might leave in a huff. so I won't say that. You can draw your own conclusions. To build a program like this takes incredible vision. You have to be able to imagine what you'd like something to be like 10 years from now, and something that actually hasn't existed before. And then you have to have incredible grit, because you have to come in every day after week after month and do 1,001 small things to make your vision a reality. It's not within my capacity or memory to acknowledge everybody who should be acknowledged, but Tanis, to you and to all of your team within TRAMS, the people who collaborate and digitate, Brendan, the administrative support, I hope each one of you is really proud of what you've accomplished, because this is phenomenal. And I hope you're proud not just of what you've accomplished for your patients here, but because TRAMS is one of the handful of really exemplar sites that the collaborative's message is essentially, we'd like everybody in the world to copy you. And what you've done in building this program is, in fact, having an impact around the globe. And after telling you that the message of the collaborative is that everyone should copy you, I have really told you all there is to know about a QI collaborative. You are now all QI collaborative experts. Too often in medicine, and this will be familiar to all of us, one hospital or one doctor finds a great way to do something. They reduce mortality 80%, they go to meetings, they present it, they publish papers, everyone goes, oh my gosh, this is incredible, and then everyone goes back to their home institution and keeps on doing things the same way. And the basic core of what a QI collaborative is a shared commitment to do better than that. We commit to ourselves and we commit to each other in this partnership that we're going to move the needle forward. That's a bad metaphor. We're going to move the ball forward. We learn from the best programs. We also learn from each other, because every single program that's here today is doing something superlatively well, and we need to hear about that and learn about that. We share with each other our successes and failures in implementing change, because this is really about change management. We measure to see if it worked, and then we repeat that cycle, and we keep repeating the cycle until we're happy. And that is it. You are now not only experts, you are now official black belts in QI collaboratives. It's a very simple concept, not simple to execute, but a simple concept. In great tracheostomy programs, and I've spent a lot of time thinking about this over the last few years, you will see 4 key themes. Multidisciplinary team care, which does not mean that I talk to you in the hall or send you an email. It means the physio, the speech pathologist, the pulmonologist, the ICU doctor, the ENT, and the nurse, and whoever else is involved sit down in the same room at the same time and talk together about the patients and make decisions together. Standardization, great programs have care pathways, and obviously many patients need to be taken off the pathway because they have a medical situation that demands that, but random variability and random provider preference variability is the enemy of superlative care. Terrible things happen, and I invite you to go to our homepage, and you will see actually a couple of these videos today, I think, in Brendan's talk, but on our home webpage, you can see a couple families tell you what happens when a patient has a trach emergency at 1 in the morning, and the nurse at the bedside and the doctor on call, through no fault of their own, are not prepared to deal with that. The patient dies, the family's scarred forever, and of course the providers are scarred forever. It is not fair to the patient, it's not fair to the family, it's not fair to the provider for us to allow that to happen in our institutions. I won't dwell on patient and family involvement, except to say that it's been a key part of the collaborative from day one, and I assume that everyone here understands how important that is. We've put a lot of effort into building a measurement tool. And we'll ask you if you join to put some energy into measurement. Not a lot, not an onerous amount, but some. It's really important to understand why we're asking you to measure. We are not a research project. It is not our goal to find out if the trach should be changed on day 5 or day 8. Now, when we have a database of several thousand patients in a few years, there will be opportunities to do research. We will have a moral obligation to do that, and we will dive into that database and find out things and share them with the world. But that is not the primary reason to collect data. The primary reason to collect data is there's one thing that is absolutely 100% true in the world of QI, is that if you measure things, they get better. If you know that how you did this year compares to last year, and you know that how you do next year will be on that same graph, and if you know that your CEO is going to be looking at that graph, you will get better. If you know how you compare to an average of similar hospitals, like yourself, and it's below average, you will get better. And let me just give you one small example of the value of measurement in motivating change. We have the US on the bottom here because we're sticking with our geographically appropriate hemispheres. In the Boston kickoff meeting, in a country of 315 million, we had 14 hospitals, which gives us 4.4 hospitals per 100 million population. I thought that was not too bad until we had our London kickoff, where we had 29 hospitals in a country with a population of 60 million, which made me feel embarrassed, but not utterly humiliated yet. To be utterly humiliated, we had to wait for today, where we have 90 institutions in a country with a population of 23 million. Now I'm utterly humiliated. And since the Board of Trustees of the GTC is going to be looking at this graph, and since when we have our next kickoff in 2 years, they're going to be looking at the subsequent graph, I am going to be highly motivated to raise my bar. So measurement drives improvement. I'd like to tell you again that this is a team effort. It's a great privilege to stand up here and speak on behalf of the entire team. But let's not forget the fundamental truism of academic medicine, which is the amount of work you've done is in linear relationship to your distance from the podium. And some of these people are 10,000 miles away, so you can figure out how much more work they've done than me. These are the people who've done the work. Everybody in this picture has put in hundreds upon hundreds of hours. They're not getting paid, and in fact, when they travel, we don't even fully reimburse travel because we can't afford to. They're not getting promoted, they're not getting famous. People are putting the hours because we believe it can be better. We invite you to share our conviction that trach care can be done better. I'm sorry, let me take one step backwards and say, in addition to being a ton of work, it's been an absolute blast. There are not many things in life that are more fun than working hard with great colleagues to do something that you know matters. We invite you to share our conviction that care can be better, to share our commitment to making it better. We invite you all to become our friends and our colleagues, to have a great time together on a fantastic project, and to make things better for all of our patients. Thank you.
Thank you, David. I've now got the privilege and honour of introducing our next two speakers. Firstly, Professor Tony Narula, who's come to join us from London, where he's an ear, nose and throat senior surgeon at St Mary's. I'll get the joke in before Tony does. It's not often that an intensivist dresses more formally than a consultant surgeon. So this one will have to go down on the record as one of those very few instances. And Tony will be sharing with us the UK perspective. It's also my pleasure to introduce a colleague, a friend and a mentor, Dr. Graham Duke, who's a senior intensivist at Eastern Health in Box Hill. Graham gave me my second ever consultant intensive care job, and I'm sure has been ruining the day that occurred. And he'll be sharing with us some insights from Australia and sharing some of the data that he's been reviewing, particularly from Melbourne and Victoria. So without further ado, I'd like to welcome Tony and following on, Graham.
Thanks, Steve. So we can have the slides change, please. Thank you. I thought Australians tend to be quite informal and dress down, so I made a big effort to dress down. So that went really well, didn't it? Just trying to fit in, okay? I've only got a few minutes, I'm going to rush through this. Can I begin by saying to all the Australian and Southeast Asian people here, I have not come to tell you what to do. Please, please, please. I've come to share what we have found, but I'm not here to tell you how you should run things. You've already heard that so many of the best innovations in this field of care have actually come from this city. So you don't need me to tell you what to do. You'll hear some more details about the UK information later from Brendan. So he and I have combined to try to make sure our slides don't overlap. Or to be more honest, where's Brendan? He wrote the talk for me, so thanks, Brendan. Normally you get your resident to do it. So just a bit of background. That's what they're for, isn't it? They're 12,000 miles away, they're working hard. So in our country of 60 million, you're looking at about 5,000 surgical trachs a year. It's just over a third of all trachs. And you can see the number of incidents and the very high number of those which are serious. And as to what sort of harm, some publication from Brendan's team in 2009. Displaced and blocked tubes are without doubt the biggest area of problem. He did a review that was published on 968 incidents, and it's extraordinary. These are in hospital, 3% deaths. This data from 2009, 9-10, we have up-to-date information in the UK, which will pop up later, which shows that this remains the case. This is not a small problem. David and his team published in the Laryngoscope 2 or 3 years ago a US survey. It's the same there, and it's probably the same here. Interesting point that was previously shown by my colleague from Manchester, that if you're on a ward, as opposed to in intensive care, the chance of harm is much greater. This is, of course, intuitive. One of the biggest things that we have identified in the UK is that with the rising number of trachs being done, because of the better survival of the elderly and multiply sick patients, they get dispersed all around the hospital and no one knows where they are, and sometimes no one knows what's happening to them. A national audit, this is from about 3 years ago, looking at ICU cases. 11 out of 14 death or hypoxic brain injuries. Absolutely scary. These are, of course, avoidable problems. You'll hear later from my friend in Johns Hopkins about the cost in dollars of one of these incidents. It far outweighs the cost of improving services. In Britain, we have this institution called the National Inquiry into Patient Outcome and Death. It's a very highly respected organisation. It's run at arm's length from the government. And last year, they decided to run a detailed inquiry on tracheostomy patients. That means that in Britain, with socialised healthcare, every single patient in the country who had a trach over a 3-month period had to be reported. And then a sample of those patients were analysed in detail by the team from this organisation. So you'll see some more data later on, but let me just share with you the number of complications. So 30% of patients had more than one complication. That's pretty scary. And here are some of the complications. You see on the third bullet point, you see what I raised earlier. This was confirmed in 2013. Ward patients more likely to suffer problems. 30% of patients did not provide a training program. In fact, in our own department, which I'll touch on very briefly towards the end of this talk, what the regular training program has done is equipped particularly nurses and allied health professionals who are on general wards, equip them with the confidence to handle patients who otherwise they found quite frightening. I'm sorry to say the medical staff tend not to come, but that's, you know, we already know everything, don't we? You know that, yeah. So these are key recommendations, and every hospital in our country now, as of 2014, every hospital in our country has to respond to these recommendations, has to report to their board of directors, because this has national clout. Quite interesting, one of the things they found was discharge from intensive care. A lot of patients were discharged between 8 p.m. and 8 a.m. to outlying hospitals because they needed the beds. So they'd call an ambulance, say, at midnight and stick a trach patient and send them back to the originating hospital. Quite scary, eh? And capnography, interestingly, that's an anesthetic thing, so clearly it's not of interest to me, but it shows you if there's no CO2, you're not in the airway. It's actually very simple, isn't it? Nobody would do a central line now without ultrasound guidance. When I was a young doctor, you just did it because you roughly knew where the subclavian vein is, and you stuck a needle in it. It was okay. It worked most of the time. I did watch somebody years ago doing a jugular line, and when he pulled out the stilet and the common carotid spurted across his shirt and his right shoulder, I realized even back then there must be a better way. So very briefly to touch on my own institution, which is a historic institution almost as old as the state of Victoria, I think. Actually, maybe older, 1849. I don't think Victoria became a state until after that. You were still part of New South Wales, if I'm not mistaken. But the gold rush had probably already happened by then. So this, you can see my interest goes back about 10 years, and you can see the serious incident, reported incidents. And what I'm just going to show you is you can do it step by step. You mustn't be afraid if you're working somewhere where there is no organized care pathway. Do it bit by bit. You will be amazed at the cumulative power of incremental changes. So we introduced a care bundle, which basically was a set of standards at the bedside, which had to be audited. And having initiated the audit, as David points out, once you start measuring things, people start paying attention. And in fact, this decline is real because once you start measuring and people start thinking, they're more likely to report things. Then we introduced a tracheostomy multidisciplinary team ward round, and we're not running at 0%, but it's below 5 year on year. And look where we started, bit by bit. This is our current team. You can see we've got pretty much everybody that David referred to. I try to remind myself the patient is at the center of all this, but you know, the busier you are, the easier it is to forget that. And just to show some hard facts for Brendan, who's the CEO, this is the kind of money that can be saved, Brendan. We have published this data. So with a multidisciplinary team ward round, look at the decannulation time of patients who are now off ICU. Look at the cost saving. And look at that last line. If you have a trach for 1/3 fewer days, you have 1/3 less time in which something horrible might happen to you. Really horrible. Just to refer back to the national study in Britain last year that I mentioned to you, the 3-month analysis, 450 or so sets of notes were analysed in detail in 1 quarter. There were 4 cases of death or severe hypoxic brain injury in 1 quarter. So it's pretty scary. I must acknowledge Brendan, not only for writing the slides, but for being the key driver of the UK part of this organisation, wherever he is, and for leading the National Tracheostomy Safety Project. So I hope I haven't told you what to do. I hope I've given you a bit of context and a bit of personal information that shows that, yes, we can do it. So on behalf of the GTC, and credit to our founder, David, Thank you all for listening.
Thank you very much for the invitation to come and share with you. I apologise for my voice. I'm recovering from altitude sinusitis. The tracheostomy scene is something that has fascinated me for my 30 years career, and I've looked after a lot of patients and found it most enjoyable and a lot of fun, and I'd like to share with you some of the aspects that may be either unique or special or interesting about the Australian perspective. I think we do have a lot to learn from those in other countries, and despite what the previous two speakers have said. So I come to you as a practicing clinician. I don't class myself as an expert by any means, but what is unique or special or interesting about the Australian situation? Well, David's already showed you that where Australia is on the world map. But not only that, most of you will know that last year Melbourne was voted the most livable city. Not only that, but 5 of the top 10 livable cities are in Australia or New Zealand. And the other 3 are in Canada and a couple in Western Europe. What else is unique is we have an interest in putting tracheostomies in just about anything moving. So here's the first tracheostomy performed in a koala last year up at Steve Irwin's Animal World Zoo. And that's Callista. And we're happy to put tracks in overseas visitors as well. Some of you might remember the the unfortunate event back in '95 where the Finnish Formula One driver Mika Hakkinen on practice on Friday afternoon blew out a tyre and at 130-40 kilometres an hour went into the rail and suffered a head injury and had a tracheostomy there at the roadside, and survived to then go on, I think, to win 2 back-to-back Formula Ones. A bit like a Victorian football team who won back-to-back premierships after their coach developed Guillain-Barré syndrome in the middle of the year. Anyway, sorry. We've also had quite a lot of publications come out of Australia of interest, and there's a long list, but and I've just put up 3 on the slide. So the first one on the left-hand side is Bill Griggs from 1990, who published his percutaneous dilator method, which many of us used for a long time. Bill Sylvester at the Austin and the crew did a randomised controlled trial of percutaneous versus surgical tracheostomies at the bedside, which many of you will know about, or as I like to call it, Simon Knight versus the rest of the world. And then also equally important, Anthony Tobin at St Vincent's Hospital published a very interesting paper about the effect of tracheostomy teams on decreasing length of stay in hospital, time to decannulation, very similar to what Tony showed you previously. So that's some of the interest that's occurred. And as the other speakers have pointed out, there's about 90 hospitals represented here, and we've got about 45 trachea teams, and a lot of them, probably about 1/3 of them, are here from Victoria, which is just fantastic. So what about the Australian healthcare system? I think it's important just to point out for those who are visitors what the differences might be, because it's important when you hear speakers or when you read. Similarly, for those of us who are Aussies, when you read overseas papers, it's important to understand some slight differences. So as you know, we've got a population getting close to 24 million. We've got a universal public healthcare system, plus a fairly busy private sector, which the community can opt into, and it accounts for about 30% of the acute healthcare workload. We've got a bit over 1,000 acute care facilities and about 9.5 million acute care admissions. So in world perspective, it's tiny. Equally so, the number of intensive care units across Australia is about 175, so 17% of the acute care facilities have intensive care services on site, and roughly 145,000 admissions. One of the important differences in Australia, we don't have what's called in North America the long-term acute care facilities, or LTACs. Most of what would be performed in LTACs in terms of managing difficult weaning and tracheostomy patients would be standard care in acute care facilities here in Australia, so it's an important difference. What about the number of tracheostomies? Now, this is a close but a rough estimate, probably around about 18 trachees per 100,000 patients. But one of the most important things that I've had there in the right-hand column is they're a sick group of patients. Their mortality, hospital mortality here in Australia is about 15%. That means that if you have a patient in hospital with a tracheostomy, their mortality is about 10 to 15 times what the average hospital patient mortality is. And where do you find those patients? About 17% outside the intensive care ward in the ENT, head and neck surgery wards, thoracic wards, spinal wards, and neurosurgical wards, etc. But only about 3% of them are permanent tracheostomies. And by far the majority of tracheostomies are performed on intensive care patients, mainly because of neurological injury and or long-term weaning. But you can see, again, the mortality in this group is pretty high. That's not necessarily attributable mortality, it's mortality related to the underlying condition. So given my personal bias towards intensive care, what's the story in intensive care? As I said, there's about 140,000 admissions. The mortality for the average intensive care patient in Australia is now dipping below 10%. The ventilator subgroup is just under 50% of that total workload, but their mortality is higher, as you'd expect. And about 6% of that ventilator group undergo tracheostomy. As I mentioned before, only a small percent are referred to the few LTACs, or like the Victorian Respiratory Support Service. Interestingly, the mix between open and percutaneous is about 50-50, and it's been that way for a long time. This is just a breakdown of some of the intensive care diagnostic subgroups and the rate of tracheostomy over the last 12, 13 years. And I guess probably the take-home point is just to say that the group of patients who have tracheostomies is a highly varied, heterogeneous group, and the rate of tracheostomy in those groups differs enormously, from as low as 2% in the cardiac surgical group to as high as 60% in the Guillain-Barré group. This slide is the rate of tracheostomies in the 23 intensive care units in Victoria in terms of trachs per 1,000 ventilator bed days. And I only put this up mainly to show you the enormous variation. Now, the red bars are the tertiary referral hospitals. The green bars are the other metropolitan non-tertiary hospitals, and the blue are the regional or rural hospitals. And if you look at any of those colours and compare them, there's enormous variation, about a fourfold variation in practice. So that means that people working in the hospitals at the left end of the graph are getting a lot of experience, and those on the right-hand side are getting much less experience. And it's not due to differences in case mix. This is just a graph of the rate of trachs in intensive care patients over the last 12 years. And you can see that the rate is falling dramatically. There are a number of reasons for that. And that's the solid line, the dotted line and the dashed line are the different methods. And so finally, just a comment that tracheostomy teams in Australia are similar to anywhere else you'd find. And I have to make an apology. When I put together this final slides earlier yesterday morning, just before I sent them off, I realised that I'd left off the last dot point, which the two previous speakers have reminded us are very important. And I make two small comments and then I'll finish. The importance of the patients is that I think it would be without a doubt that I've learnt the most about tracheostomies from the patients. And if you listen to the patients, they'll tell you an enormous amount and you can learn a lot. And then in 2 hours after I'd sent these slides off to Gavin for this presentation today, I walk into the ward to see two of our track patients. And as I'm explaining to one of them, he says to me, "Yes, we're all in this together," which I thought was a great little way of describing it. So the challenges are similar to the previous speakers. We've got a huge number of healthcare professionals who look after tracheostomy patients. We've got de-skilling in the hospitals with few trachs. We've got problems with education. We've got concerns about patient selection. How do you manage routine care and all of the thousands of issues related to that? How do we develop a simple clinical skill set that's simple and safe that enables everyone to manage tracheostomy patients without causing the horrible deaths and complications that Tony mentioned a moment ago, which do happen in Australia, unfortunately, also far too often. And the three big problems that I see in terms of acute life-threatening problems to manage are the bleeding, the dislodged and the blocked trachea, as you've previously mentioned. So what are the benefits of Australia getting on board and involved with the Global Tracheostomy Collaborative? Improved patient safety, providing clinical practice resources to those who need them. I think the data registry is a fantastic idea and is sorely needed. The building of teamwork, and so the message from all of us is become a member and get involved, and tell those who are not here today to get involved. Thanks very much.
Thanks, Graham and Tony. I'm now delighted to introduce our next two speakers, Erin Ward and Christy McMurray. Erin and Christy are giving some of the most important presentations of this morning. They're going to tell us some crucial stories that remind us why we're doing all this. Erin's joined us all the way from the US, and she'll share with us a little about her own circumstances and story. Erin's a powerful advocate for optimal tracheostomy care, and having someone like her in the room when we're having often complex and challenging discussions about data sharing agreements and all of those really important administrative requirements for doing all of the great work that we do. She's a great reminder of why we're actually doing it. And having someone like her around to provide those timely reminders and the inspiration has been crucial to our work. I'm also delighted to invite Christy up to share her perspective on the patient's experience. Christy is one of our highly engaged, incredibly knowledgeable and experienced nursing team at the Austin, and she'll share with us a bit of a patient journey and narrative, which I think will be one of the things that you'll take away from today, is some of the data and some of the great talks that we've had from various professional experts. But I think it's the patient narrative, that journey, which is what really inspires us, and I'm sure that's a great deal of what you'll take back to your own centres. So without further ado, welcome Erin and Christy.
Stephen, help me load up my slides. Thank you so much for this opportunity. I want to thank the Australasian team for inviting me to be here in person today to share a bit of my story. And I want to thank all of you for taking time out of your very, very busy professional life to be here. When I first heard about the formation of a global tracheostomy collaborative, it was such an honor to be asked by David Robertson to be a part of that project from the very beginning. Patient and family involvement is really important, and I've had a lot of previous experience with patient and family involvement, but oftentimes we're brought into the process much later. So to be able to be part of it from the very beginning was really profound, and I was really grateful for that opportunity. And also, I think it's really important to recognize that the GTC Steering Committee as a whole has now made it one of the key drivers. So it's really important. In addition to all the professionals that are here, I want to say a special welcome to all the patients and families that are in the room, and I'm very much looking forward to getting to speak with you in a little while. I think I'm pressing the right way. This one?
Click the left side. We are.
We are. So while we're waiting for the next photo, I can share with you that what has brought me to this journey is that I have a son who is now 13 years old with a tracheostomy, and he has a rare form of a muscular myopathy called myotubular myopathy.
It should work now.
Okay. So here's William and my husband Mark, who's my partner in care. And I'll say good day, mates, because they are watching over in Boston as we speak. No, I'm still clicking. Pardon me?
Slide out the keyboard.
Okay, sure.
Maybe just
This one? Okay. So our journey started 13 years ago. He was very fragile in the NICU. He probably looks very similar to many patients you encounter. And our motto has always been, a little will can go a long way. And I'm very proud to say that 13 years later, he's living successfully in our home. After our time in our NICU, he's only had one hospitalization and one ER visit in the 13 years. Now, I have to pause and say that's with a lot of complex care. We run almost an ICU in our home. But he does go to school, and he has a lot of hobbies. And I think that this is, the reason why I'm sharing this is not so much to learn about Will, although he's a cool kid, is for you to think about how important it is to get to know your patients and what drives them, either children or adults. And beyond having a tracheostomy, they're a person first. So being a patient and a family member with a tracheostomy can often be an isolating experience. So in 2006, I got together with a group of moms, and we created a group in Boston called trachecare.org. And our goal is to bring together patients and families to have an opportunity to spend time together, learn from each other, share resources. I moved on from that and also continued to do that, as well as I've gotten more involved in my son's diagnosis community. And here is a biannual conference, and you can see that in my son's diagnosis community, many patients need tracheostomies and vents. And they're thriving, and they travel across the country to come to our conferences. So I think it speaks volumes about how important the connection is between patients and families for both children and adults. Family leadership in healthcare in general is not a new concept, and it's really important for us to acknowledge in our tracheostomy community we've had some profound families involved that continue to be involved. And Cindy Bissell is one of our partners in the collaborative, and she founded Aaron's Tracheostomy Page, which is a leading resource. It's also, about 3 years ago, so just about a year before the global tracheostomy took off, families got together and decided we need to have a week to celebrate tracheostomy care. Oftentimes we feel like maybe we're an overlooked population. So this occurs every third week in May. So just to highlight some of the challenges that, in speaking with families across the globe, some of the universal things that seem to happen for all of us is that our care is often fragmented. It's not because there's not fantastic people that we're working with, it's just the nature of our systems are often not set up for that coordinated care. Communication is often relied upon to be relayed between the family and individual providers. We're put in the middle of the conversation. Lack of care coordination, and also in our families and our communities, we're often trying to overcome myths and stigmas. Specifically in inpatient, it's really interesting. There's people that have an opportunity to have discussions about having a trach placed or not, and then there's also emergent tracheostomies that have to be performed. And a lot of the pathway that has to follow from having a trach is the same, but depending on the entry point, sometimes the communication and education is different. A lot of times, especially when there's not an opportunity to have a multidisciplinary team rounding system, people are left wondering who's in charge, which specialist. important issues like feeding and speech and therapies are sometimes introduced much later than a patient and family would prefer. And the idea of having emergency protocols no matter what ward or unit your family member winds up in. Here's a member, a child who's 13, and he had a situation where he had to be in for a surgery. And due to the surgery, he had to have a cuff trach temporarily. While he was receiving treatment, a cough assist treatment, they reattached him to the vent, but unfortunately, the people in the room did not turn the ventilator back on. He's safe, he's okay. His mother was in the room and was able to read him well enough to know that there was a situation happening. But it was traumatic for him because where he typically is able to communicate, he had the temporary cuff trach. So even being in a good place, a good hospital with people surrounding him, it just shows how vulnerable our population is and how sometimes maybe our family members seem to be not wanting to leave the room. These are some of the reasons why. So moving on from inpatient experiences, something that's come to the surface as a big priority is looking at transitions issues from an inpatient experience to either to a home or a facility, rehabilitation facility. And the challenges around discharge planning. I say that oftentimes it's one person in a hospital given those responsibilities to helping discharge families and the unsung heroes for many of our families. Resources in the community really vary from what country you're in or what state. Family resources really vary. People's ability to be able to care for a very complex adult or child at home. And the importance of training and resources. Specifically, a gentleman, Colm Young, from a father in Ireland, brought to our attention the issues of transitioning home and how so much of it was around the care packages that weren't happening. I use this as an example of the power of the voice of the patient and family. They were able to get attention of the healthcare minister and was committed more money dedicated to helping families come home. Now, unfortunately, recently, I received another follow-up email from him that because of changing government leadership, that in fact, they were back at the drawing board trying to do the same thing for this next fiscal year. So one of the things I've had an opportunity to do is learn the differences about, in the States, we oftentimes are appointed skilled nurses to take care of our children and adults in home. And in other places, there are care providers that are lay people that are trained. But it's amazing to me how similar the challenges are, and that just because a person has an RN degree in the States doesn't necessarily mean that they've had any training on caring for people with trachs and vents. And then here in Australia, I had an opportunity to speak with a family and how they could train someone, a layperson, and they could be extraordinary. But no way is they're not compensated for the level of care that they're providing. So insurance coverage and cuts face us all. Sometimes getting the basic equipment that we need in our home is an extraordinary challenge. And again, coordinated care seems to be lacking. I was really touched by this news article that came across my feed. Here's a Chinese farmer who built a ventilator for his son. And his quote said, "We never think of giving up, not for 1 second." So the lengths that patients and families will go for their loved ones is extraordinary. So this is just an image of oftentimes we feel like the communication is really two-dimensional between ourselves, our patients, and all the multiple providers. And our hope would be that, I call this kind of the diamond standard, that there would be much more collaboration, coordination. So these are the core drivers, the key drivers for the collaborative. And all of these, even though there's a separate one for patients and families, all of these will benefit patients and families. So our wish list, partner with us, help us form our plans of what we want our children and our adults that have tracheostomies, what their care should look like. Be transparent with us. Look to us to define quality of life. So oftentimes in the medical field, we think of that solely based on physicalities and medical situations, and oftentimes what I've been so moved by is how families redefine what that means for them and often reach a deeper appreciation for life. help us transform hope, talk to each other, and engage us. And that's one of the core things here I'm going to speak just very briefly about, is with the GTC, we are really looking to engage patient and families. Our hope is that each hospital that enrolls will have a patient or family champion. This is a big part of my work, along with Melissa, who's a nurse consultant here in Melbourne. We have been reaching out to leaders in the community and bringing them in as advisors. And also we want to be accessible to all your patients and families. So people can be involved by signing up for our free portal membership, sharing your story, helping to raise awareness, helping us identify resources. I recently had a request to find a support group for adults in the UK, so doing my best to locate that for people. Spreading the word to providers. They can be your best ambassadors, especially as you want to enroll and you're getting resistance from hospital leadership. Having a patient or family member speaking up and saying how important this is can be crucial. We did have an opportunity to do a patient and family survey, and within a matter of 2.5 weeks, we had over 200 respondents using social media. And the patient and family voice globally is strong, and they want to be involved. So we'll be, hopefully in the next several months, rolling out some results from that. And at each of our kickoffs, we have had a patient and family component. The photo here is from Boston, and then we had Malcolm Babb, who's the head of laryngectomy clubs in the UK. He also spoke at our family forum in London. So the way that you can contact us is myself and Melissa. We have a separate email for the GTC where we try to direct patient and family requests. And this is one of my favorite quotes: never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. And I just want to say a personal thank you. I don't think she's in the room quite yet, but she'll be joining us for lunch. I had a wonderful opportunity to spend Sunday with a local Melbourne family, the Gibb family, and this is their son George, Russell and Michelle, the parents, and the siblings, Andy and William. And it was a enriching day where we had a chance to share common experiences. Even though we're halfway around the world, our experiences are something that bond us immediately, and the power of that. So I want to thank the Gibb family, and looking forward to meeting everyone else in the room today that took the chance to be here. So reach out to us, engage us, and let us help you engage patients and families. Thank you.
Thank you, Erin. How do I get this out?
Okay.
Or even escape.
Just click up there.
Okay. We might just use the bottom. Hi. I'd just like to say thank you to Erin for speaking on behalf of the family perspective. And also thank you to the GTC for allowing me to speak on behalf of in particular, the adult patient population that we have here in Australia. I'm part of the TRAMS service, which operates at Austin Health. Essentially, it's two arms that are highly structured and a multidisciplinary team. We have similar goals and themes, whether it's acute or community, and they are to improve the safety of care and reduce adverse events. We aim to reduce the length of stay and collect data and establish best practice guidelines. In the community in particular, we ultimately aim to empower patients and caregivers, provide a structured education and training program, but also unique to our service and the VRSS is the provision of equipment and consumables. We aim to reduce tracheostomy-related hospital readmissions. In the ideal setting, the same team that looks after the patient when the tube went in, so from intensive care or on the wards, is the same team that follows the patient right across the hospital journey and then on into the community. The TRAMS community program supports patients and family without any ventilation in the community. At the Austin, we also have another service, the Victorian Respiratory Support Service, that operates with the ventilated tracheostomy community, and some of those members are here today, and theirs is also a multidisciplinary team. They provide, we and them provide discharge planning, education, equipment, case management, and also help with the tube changes. We've shown that with the TRAMS team have shown, and with the multidisciplinary team, that patients can leave the hospital sooner, but also stay out of the hospital. As Erin has mentioned, and the several speakers this morning, is that the challenges that we face are not unique to one organisation, one state or one country. We all have the same challenges of finding the appropriate discharge destination, also ensuring that the skilled staff looking after the patients, we can provide the education and training, and also that the resources that are required to sustain that are ongoing. We need to address that the psychological impact to the patients and the carers is also considered. And like Erin was saying, is that the communication and coordination is core. In particular, while I've spoken a bit about the TRAMS service, I'm really here to speak on behalf of the patients. He's not here today, but Colin is a very inspirational person from he's a spinal cord patient. His journey began in 2011, where on a farming accident he sustained a C6 spinal cord injury. He eventually was decannulated, weaned from ventilation, went to rehabilitation and went home. Now, unfortunately, due to the position of his fixation and his weak intercostal muscles, he wasn't able to sustain life without a tracheostomy. So he had multiple representations with aspiration pneumonia, and he subsequently got his tracheostomy put back in. I'm going to show you a video that he's gratefully done with us, and this is his story. He provided, when we started our discharge planning, he provided with us a set of goals that we had to consider when we were considering what his care treatment would be like. And they were to be as independent as possible. He wanted to be treated with respect. His aim was to drive a vehicle at some point, to feel safe and cared for. He wanted to be in control of his care and responsible for his decisions. He didn't want to be housebound, and he wanted the right to be involved in planning his week and determining the types of activities and their duration. He'd also been a really strong member of his community, and he wanted to return back to those activities. This is his story. Oh. Are we going to be able to play it? Yep, there.
I'm 65 and I've lived at Melbourne all my life. I've been a dairy farmer for 45 years. And when I decided to slow down, I was milking about 270 cows, and with the cattle I was running at around 400 head, and with the land I owned at least was running about 500 acres. I just went off to work one day and didn't come home. Simple as that. It was hard on Jenny, it was hard on my family, it was hard on my friends. 16 months in hospital, and every weekend I had visitors. During the week I had visitors. When you're in a farming community, your neighbours and friends are so important. I've been involved in things like the CFA for 45 years. I was an inaugural member of the Woodworking Club for about 23 years. I've been the president, I've been on the committee. When we did have kids, I became involved with their sporting activities. I used to go to football every week. Well, since I've had my accident, part of my life's to try and get back into the community. I kept on getting chest infections. They'd chuck me off down to ICU. I'd spend 3 weeks or a month there, and then I'd bounce back. I was pretty fit. I'd go along for a bit longer, back another chest infection, back down to ICU. I wanted a life. So I just woke up one morning when they come around and I said, I'm going home with a trachea.
TRAMS stands for the Tracheostomy Review and Management Service. It's a multidisciplinary team consisting of doctors, nurses, speech pathologists, physiotherapists. A tracheostomy is quite an overwhelming, high-level care piece of equipment. It's an artificial airway. To be able to help patients and their carers, their families, become comfortable and knowledgeable about how to manage that tube is really important.
The two main problems that you have with your breathing after a high spinal cord injury are weakness of the muscles that help you to breathe in, so you can't take a very deep breath in, and the other problem is that your abdominal muscles aren't working either, so that when you try and cough, you don't get that strong cough with the push of the abdominal muscles.
They really knew the decision I made was what it should have been, and then it was just a matter of then sitting down and working out a program with the new equipment. I have the nippy, 3 cycles, 3 times. I have that every night and morning.
What the nippy does is help to give a person a really big breath on their inspiration, and then it draws the air out very rapidly on the exhalation, simulating a cough. So it helps to draw out the air and the secretions from the lungs.
In relation to the carers, we have a very structured program. It's a minimum of 2 weeks prior to someone going home with a tracheostomy. And we go through all elements of the tracheostomy care and training. They'll learn anatomy and physiology. They'll learn about suctioning. They'll learn about how to humidify the lungs.
TRAMS worked out a system that would give me a life.
We want to really give independence back so that they don't need to be managed in a nursing home or in a care facility. We really want to make sure that they can go into the community.
With the running of a farm, the goal is to set up a paperless bookkeeping system, which I'm working on at the moment. I've just received the car that's all been modified for me to be a driver, and I've made up my mind I'm going to drive.
That was one of the first questions Dad asked me when he was in ICU, when he woke up, was what about the wedding?
I was in ICU and I was pretty sick at the time.
We just sort of worked through the process, and that's where TRAMS and everyone came involved in.
So I had everyone running around, physios, doctors, nurses, OTs, TRAMS.
His big goal was to walk me down the aisle. Dad was going to get me down there one way or another.
There was just so many hurdles to overcome. I'd had 12 months to work out a speech. It was a pretty proud day, to be honest. It was just fantastic.
So ultimately, I want to thank Colin and Jenny. Unfortunately, they're not here, but they will be here today. So, and as you can tell, he likes to chat, and he'll be more than happy to have a chat. But this is how dedicated that they are to the cause. They're getting up at 3 a.m. this morning to be here. It takes a long time, so do make them welcome. I just want to, watching that, it does make me realise just how much the whole team at the Austin were involved in his discharge plan, and how wonderful it is that his goals that he gave us at the start of his journey, we have actually managed to do every single one of those now. He's driving the car, that was the final one. So it's really good to keep that in our minds when we're thinking about the patient and what is going on when they go home. So in closing thoughts, just want to reiterate that patient-centred care does change lives. The multidisciplinary teams are effective, and that while tracheostomy care is improving around the world, we've still got a long way to go. And we've got so many different teams here today, which is really exciting. And if we can all collaborate and share our knowledge, I hope that we can, improve and move forward together. And the GTC is a wonderful thing that has been created that we can all be a part of. And I'm sort of hoping that by hearing Colin's story, that we're inspired to work together and empower people with a tracheostomy. Thank you.
Rather extraordinarily, we're running slightly ahead of time, and there's an opportunity if anyone wants to ask any questions. A little bit overwhelmed by Colin's story, perhaps. It's pretty amazing, isn't it? Anyone got any questions? That's okay, everyone wants to get to morning tea. We're here all day. Good. All right. Thank you very much.
Thanks so much, Erin and Christy. I did want to mention that this meeting is being streamed live. Thank you to the speakers who agreed to that. And also, we have a photographer who's going to be here from about 10 o'clock to 1 o'clock. So just wanted to let you know he is, in fact, a pro bono photographer who's here to help us catch the event itself. So thank you very much. I just wanted to mention that.
Thanks, Tannis. So our next speaker is Haitham Kuba, who's got a pretty tough gig. Firstly, he's got to follow on from Colin's story. Secondly, he's just before morning tea. And thirdly, he's going to try and explain to you why you should commit to the GTC and actually potentially hand over some money to be part of it. And that's a tough gig. But I can tell you from my time with Haitham, he's a remarkable individual. And in the London Kick-off, we were very fortunate to have a global superstar in the presence of Stephen Hawking as a guest of the Kick-off. And few people could perhaps rise to a challenge someone like Stephen Hawking for being the star of the show, but Haitham actually gave it a red-hot go, which is pretty good for a Scottish surgeon, I might say. But he's another example of perhaps a relatively rare species of a highly articulate and incredibly engaged surgeon. You'll meet a few more during the course of the day. And who hails from the still United Kingdom, from Scotland. And you can ask him about that later on, perhaps. So without further ado, welcome, Haitham.
Thank you very much for that. So yeah, I do come from what remains just about a United Kingdom. It was close there, but it just shows that the way forward, I think the people of Scotland agreed, the way forward is to come together, right? Not to separate. How about that for a tenuous little segue into this? Okay, so I'm here to try and persuade you, and this should be an easy job, I think, right, of why you need to join the GTC. The fact is you're actually here in the room already, so half the persuasion job has already been done by someone else. But I think we're probably at this point, after that last video, feeling quite inspired. I hope everyone feeling inspired? And I think we can probably all agree, no matter who we are and where we work, tracheostomy care in our own institutions, in our own practice, is probably not quite perfect, okay? There are probably a few things that we can do to improve it. I joined this thing, of course, as an arrogant surgeon thinking, yeah, our tracheostomy care is great and I'm going to show the world how it's done. And I came back from our first kick-off meeting in Boston with 3 pages, very close typed, of a to-do list of all the enormous list of deficiencies in our service and all the things that urgently needed to be fixed. And it was a very humbling experience. And so all of us work in a system where things are potentially going wrong and people are at risk. So I think we can agree that tracheostomy care is something we should pay attention to and something that we should improve. Adverse events are very often down to human error of one kind or another, and simple interventions can make a big difference. And you've seen from interventions that have happened with TRAMS that apparently simple interventions, they may not actually be that simple actually, but they're certainly simple to articulate. Apparently simple interventions can make a big difference to how things go on. We've seen that at St Mary's in London, we've seen that from TRAMS, we've seen that from other places. So why do you need the GTC? Okay, some of you may be thinking, well, okay, well, why don't we just do this on our own? TRAMS did it, so did it in St Mary's. And great, you can actually go and do it alone if you wish. Okay, You can. They've done it. It is a long and difficult process, and those institutions will tell you that it was a number of years to get to where they are now. And they've had to do a lot of this work on their own, pioneering how to make these changes, and it took them a very long time and an enormous amount of hard work. And we're here to help you with that and make it be perhaps a little faster, but certainly a little easier. And the things that you get from joining the GTC, everyone knows there is a database. You get the benefit of other people's experience, not just the people on the steering committee who stand up and give talks, but actually everyone in the room. You get a shared experience. You get access to some resources, which I'll talk about more in a moment. And also you get the chance to share your own experience, and you get the chance to contribute and shape how things are done around the world. So if we go through those things first, I'm going to say very little about the database because we've got a talk on that coming up after the tea break from Hannah and Jay. And so you'll see about the database. It is a fantastic database. It's an amazing resource. Nothing is more powerful than data. Data allows you to track changes in your institution over time, to monitor adverse events, and what you won't get from just doing your own database, what you won't get from just hiring a medical student and bunging them 50 quid and saying, do me an Excel spreadsheet of all our trachea patients, what you will get is the chance in time, once we have enough data, to benchmark your own practice against other similar units, and that is hugely powerful. So the database is an amazing thing. Other things which you will get, this is a snapshot from the GTC website, is that you'll get the chance to participate in discussion groups. And this is an online discussion forum. I posed a little question on there, and I'm expecting to get answers from around the world from other people about how they address particular problems. If you have a particular thing you want to know, what kind of tube, dressing, ointment, whatever, what kind of practice, what kind of protocol, ask around. People from around the world will tell you what they do. So that's quite a useful thing. The webinars, I was a little skeptical about webinars until I saw them, and they're actually brilliant. These are web-based, live-streamed small group discussions. You have a small group of people having a chat on a particular topic, but you click on a link on the website. It's the easiest thing in the world, and you watch it online. You hear the discussion, and you contribute. You can see a little list down the side. Where is it? A little list down the side here of who else around the world is in the discussion. And you can type questions which are then read out and which shape the discussion that goes on the web live in front of you. These things are also archived on the web, so you can go back and watch them at another time if you missed the original one. You don't get to participate and ask questions then, but the whole business is very interactive and very entertaining and actually really quite impressive. And they're hosted by different institutions in turn. So you're all sitting there saying, oh, that sounds like fun. You're going to be doing one of these, okay? At some point, maybe not straight away, but at some point in the next few years, your institution is going to be hosting a webinar. So watch out, get your makeup on, because you're going to be on screen, streamed live across the web. You might want to have a think now about what topic you want to do, okay? You don't have to commit just yet. The interventions menu on here is full of loads and loads of resources. And one thing which we all stress and which we'll say time and time again is that none of this is about people standing up and telling you what to do. We can tell you what happened in St Mary's, I can tell you what we do in Glasgow, you can find out what they do here in Melbourne, but none of those things may suit your particular environment. They may not suit your institution and your patient mix. So you need to work out for yourself what to do. But what you can do is see what other people have done and use that as a basis rather than a blank sheet of paper. So for example, if we look in the interventions menu, the main drivers that we have in the GTC is multidisciplinary care, protocols, staff education, patient and family involvement. So you can click on any of those, and if you click on multidisciplinary care, then you come up with examples of how other institutions have really brought true multidisciplinary care together and made it work. So you can read about other people's experience and use that to shape your own. Equally, you can go to the policies and procedures bit and see other people's policies and protocols that they've written. Now, you may like them and you may want to steal them, and that's fine, you're very welcome to, that's why they're there. But you may say, actually, that doesn't suit my environment, doesn't suit my patients, and you may want to write your own, but you can at least look at other people's and see what they've got. So these resources are available to you if you want them. There are educational resources there for staff training and for parent and carer education. So there's lots of things you can look at which you can use to build your own stuff if you want it. But the other thing that the GTC provides is your chance to change the world, okay? You don't get these things very often. And what is really what is really good about the people in this room, what is good about you lot, is that you are the first wave, okay? And within a space of a very short number of months, we've had meetings in Boston, London, and here. You are the first wave. You are the pioneers. You are the trailblazers. You are the early adopters. You are, dare I say it, the visionaries. Because you're the ones who've seen quicker than anyone else how important this is, and you want to get in on the ground floor. So you're the ones who are motivated and keen. Now, there's other people who are not in this room, and they're going to have to be persuaded, and they'll come on board in time. But you are the ones who are going to be the first wave and who are going to demonstrate to everyone else the need to do this. So you're the ones who probably, actually, in this room are doing it, many of the tracheostomy care issues, quite well already, and you'll have loads of things to share with the rest of the world, and we are desperate to get your experience and your expertise and hear from you. So this is very, very much a two-way process. So if you're going to get involved, be aware it is an active business. So we want to hear from you. And this is really important. It's an opportunity for you to share your best practice and innovations and for you to participate in something genuinely important. Okay? So kudos to you and to your institutions. So why join the GTC? Well, you get a database, yeah. You get benefit from other people's experience. You don't have to reinvent the wheel because it's all there for you, and you get a chance to share your best practice. But the real answers, why join it? Because tracheostomy care is important, because actually affecting real change, let's not kid ourselves here, affecting real change is a long and difficult process. You're committing to a 3 to 5 year journey, at least as a minimum. And it's going to be a damn sight easier for you to do that with your friends around you, and so that's why we're here. So thank you for that. Yes, this is Hannah. She's one of my patients. The tracheostomy's out now, and she's doing really well. Good. I'll just move on, if I may, and do the next one, because we've kind of explained why. But we're going to move on from what I hope is the kind of inspirational part of the morning onto the kind of practical part of the morning. And the practical thing is, okay, if you're persuaded to join, is how do you physically go about it? So the first step is to come to a kick-off meeting. So congratulations, you've taken the first step, and welcome. I think one of the important things is that no one individual is going to affect change in your institution, regardless of what your institution is, okay? This is about working together with lots of people. So usually there will be 1 or 2 individuals in any institution who are the motivated ones, who are the keen drivers to the whole thing. And we are keen for you to start putting together this team. So wherever it is that you work, you probably already have in mind who the hospital champions are going to be for your hospital. We like for there to be 1 physician, surgeon, medical kind of person, 1 allied professional, a nurse specialist, a speech therapist, a physiotherapist, and 1 patient family champion as well. And we'd urge you as a minimum that those are the 3 that you should have. And you may have more, but we want those 3 champions. And they're the real leaders, the real drivers of the process. But you're not going to get any change in your institution unless everybody's on board. So you do have to start at this stage making contact with the wider teams. So, you know, whether that's ENT, respiratory, ICU, and all the allied professionals, all of that is important. Extremely important also, managerial support. Really, really important. I'll just flick ahead a couple. Managerial support is absolutely crucial to this because your organisation needs to change. It needs to be a pervasive change across the whole business. And lots of people will come on board very easily and some may not. So you need support from the very top to get this kind of level of change. You need to get commitment from the management in your institution to a commitment from them, preferably in writing, to facilitate the process and support the individuals to agree to get data into the database and to pay the fees. I'll come on to money in a moment. But when it comes to actually the physical business of how you join, this is on the website. There's also a written version which may well be in your pack. What we've found with the different launch meetings is that on different continents, in different legal jurisdictions, we have slightly different processes. The one that's written out for this should be very suitable for an Australian context. For those of you here from New Zealand or from Asia, you may need to just think about how this should be adapted to your own local requirements, and we will help you with that. But the first thing to do from here is to register your interest. So there is a hospital champions and user access form, we would like the contact details, you get registered, and once you're registered, then you're on our system and you're part of the collaborative. So we would want that either in writing or through the web by email to Christine to do that. The next stage in Australia is for you to get ethics committee applications in. And that may well take some time, because we all know ethical committees take some time, okay? And with the best will in the world, this whole process is going to take you between 3 to 9 months, okay? So you register now, and you get your forms in, and you get part of the, you get to be part of this collaborative as of the moment we get your registration. The actual final business with access to the database and everything may take a bit longer. But apply to your ethics committee and get that in as soon as possible. We also need the data use agreement signed so that we then have the permissions in place to allow you access into the database. Once we have those things, then you'll be given access, usernames and passwords for members of the team to get onto the portal, to join, so that you can take part in the webinars and discussion groups and have access to all the educational materials. You put in a request for an invoice at that point, and submit the payment. And once the payment is in place, you then get all the final access to the database and start entering data into that, okay? So the process is a very straightforward one. Now, this is the process, I should point out, this is the process for a member hospital to join. And that's what we're really keen to encourage, is that your institution joins, so that the whole team can then take part in an institution-wide process to change. It is possible for you to join as an individual member, as a medical staff member, allied professional member. So you can join as an individual, and that allows you to participate in the webinars and have access to the materials and take part in the discussions. And if your institution is not yet at the stage where it wishes to join, then you may want to join as an individual member and take part that way. There's also a way for staff and patient and family carer members to join, and we're very keen, if you have patients and families that are, you know, motivated, articulate, want to get involved, we're very keen that you encourage them to join, and that's free to join, and they can join as patient members, and they can take part in the discussions and help to shape and keep us all right. So those are the different ways that you can join. Money. When we had this meeting the kick-off meeting in Boston in the US, we didn't really need to talk about money. All the guys arrived with their checkbooks and they kind of signed up. They're used to paying for things, not an issue. When we had the meeting in the UK, it was a big issue, and we had a talk on why you have to pay. Because in the UK, of course, all these tight-fisted POMs, nobody wanted to actually pay any money and didn't see why they should pay money for something. So here's the thing. It costs money, and that's okay. Let's tell you what you don't pay for. What you don't pay for is Professor Tony Nerula to put on a dinner suit and a bow tie and have a big posh dinner with lots of vintage wine. I mean, he would like that. He does enjoy that. But that's not what you're paying for, okay? You know what, we do socialise. We go out for dinner, we have drinks, we pay for it all out of our own pockets. None of it comes from the GTC. There's no social, fund in this thing. You're not paying for us to get drunk. This is a non-profit organisation. It's registered as a charity in the US. We are not funded by industry. We're not funded by government sources. We're not funded by anything. We're funded by, to be fair, some charitable donations that have come in. That's where the funding comes. And moving forward, we're funded by your subscriptions, and that's it. So this is an entirely free of influence from other people. It's been set up on a pretty minimal budget, and it's been set up because just about everybody has done a vast amount of work free of charge in their own time. And it has been a huge amount of work, actually. Lots of pro bono work from external agencies as well, but a huge amount of work. And I can't describe to you the amount of work that's gone into this by various people. The cost, $3,500 for the first year, $5,000 a year thereafter, I think is true in Australia. And the reason that it costs money is because there's stuff that costs money. A database of the quality of the one that you're going to hear about, which is compliant with European Union legislation and America HIPAA legislation and a whole load of data security stuff, which is flexible and user-friendly and hugely powerful, an amazing database. That doesn't come cheap. Web hosting for good quality webinars, oh yes, you can do them for free and they're a bit rubbish, but we want good ones. We want a professional, useful service, and that costs money. Legal fees, a whole load of stuff which has to be paid for. So there are costs which are incurred. And this was what we got in the UK, which is that, the manager that lives in the basement, Ebenezer Scrooge, he's not going to release the money because our hospital will never pay for this kind of thing. And all the clinicians were saying, the hospital will never pay. Because as clinicians, we're used to hearing our managers telling us no. I don't know what it's like in Australia, but certainly in the UK, the expectation when you ask for something is they will say no. Okay? And you ask for extra staff equipment and you're just going to get told no. That's how it is. We expect it. In fact, if ever anyone says yes, we fall off our chairs in amazement. So paying to participate in a thing just seems odd in the UK, and there's been a certain amount of, shall we say, pushback against that. And actually it's completely misplaced, because when you speak to the hospital managers in the UK, they absolutely love quality improvement collaboratives. They love it. And they're part of loads of them. I had no idea. I went to our hospital manager, and our hospital takes part in a whole bunch of these, about 17 or 18 different QI collaboratives apparently, and data collections and registries and different things, for which they pay fees every year, sometimes quite eye-wateringly large amounts of money. I won't tell you what all these things are, but basically every specialty in a hospital is part of some QI thing. And there's loads of them. Hospitals are signed up to a whole bunch of them. Costs of anywhere between $10,000 and $100,000 a year are not unusual, particularly in the States, but certainly everywhere. The managers are very used to it, they love it, and they're used to paying for it, so ask them. I put together a very detailed business case for our hospital management when I wanted to join this thing. And I talked about, adverse events and costs and this and that, and I put together a whole massive big load of thing. And I had a big spiel, I had some audit data on complications, and I had all kinds of crap. And I went to our general manager, Jamie Rowe. I said, Jamie, there's this international tracheostomy quality improvement thing. He said, fine, no problem. I mean, this was the conversation. I was prepared for a big fight. And he said, yeah, no problem, send me an email, we do loads of these, this sounds great. And he's a bright guy. As soon as I said tracheostomy, he thought, that sounds like something where you might get problems. Yeah, let's... And that was it. Absolutely nothing. I had loads of stuff prepared. I'd had his wife tailed by a private investigator for a couple of weeks. I had photographs of his sleeping children and children leaving school. I had a load of stuff in my back pocket ready to use, which I'll save for something else. But this one, seriously, I felt totally deflated because I had a huge, big speech prepared. And he just agreed to it straight away. Not a problem. And so, anyway, when I spoke to other colleagues around the UK, they had problems. And I don't know if this would be familiar to you, but what I think they'd done was they'd gone to the everyday, day-to-day, middle-level service manager. So in the UK, this is the person that comes to me and says, why were there only 3 operations on your list on Thursday? Why was there only 3? You're supposed to do 4. And why did you order 5 pencils yesterday? You only order 4 pencils a week, and you used 5 pencils last week, and why is there a 5-week turnaround for letters and blah, blah, blah. Right, so they're the ones that are there to count the pencils and on a day-to-day basis to micromanage the minutiae of my life and when my bloody toilet breaks are and Christ knows what. And right now, they're very important people in the institution, okay? Because someone's got to count the pencils, and I'm not going to do it. So they are really, really important people, but they're paid to look at the minutiae of the day-to-day. They have no concept of, medium to long term. They have no concept of anything beyond next week, because that's not what their jobs depend on. So if you go to the day-to-day, middle-level service manager person and say, can I have a few grand because I want to put some data into some American database thing, then of course your answer is going to be that, right? Of course it is, of course. And what you want to do is actually go to the right person. You need to find the person in your organisation, and you probably know who this is, each of you, who is a strategic level senior person, someone who does look at your institution on a 3 to 5 year time frame, someone who has an overview of the fact that there is a whole bunch of QIs that they're signed up to from different disciplines, who sees the benefit of that, a strategic level person. And so clearly, my guy, Jamie Redfern, is that guy. I chose him on purpose. And although to a large extent the GTC is about the database, and the database is amazing, actually it's not about the database. It's about a process of quality improvement over a number of years, and the database is just one thing that drives that. So you're not paying to put money in a database, okay? Because you can bung 20 quid to a medical student to set you up an Excel file, blah, blah, blah. But that's not what you get here. You get something much, much better. It's worth having a chat with colleagues in other disciplines about what other QIs your hospital is signed up to, just in case your strategic level person isn't quite so strategic and doesn't realise. But if you've just seriously, on the staircase in your hospital, just grab 3 people and say, you signed up to any QIs, you'll probably find there's a bunch of them out there that you'd never heard of. The other thing which certainly is very powerful in the UK, and I'm sure this would work here, is mention other hospitals. So if you said, well, Sydney and Adelaide and everyone joined up, you know, and here we are in Melbourne, what are we going to do? So, of course, you know, these rivalries exist. And so mention the other hospitals that have joined. And actually, at this stage in the collaborative, there is a huge list of people that have already joined. Big institutions, small institutions, children's, adults, tertiary referral, you know, secondary care, the whole works. So there's loads of places have joined. It's really gathering momentum now. The real question is, why the hell wouldn't you join, I think, for your managers? The hospital, of course, gets a certain amount of kudos. They get to badge themselves as the kind of place that takes part in a tracheostomy QI, okay? Because you want to be the kind of place that takes part in a tracheostomy QI. You certainly don't want to be the kind of place that doesn't take part in a tracheostomy QI. You know what I mean? So that's important. I think you can collect some audit data. Even in an adult ICU, you probably just need to collect data for a couple of weeks, and you'll have a nice list of near misses and potential adverse events and things that weren't perfect. And if you show your managers 2 weeks' worth of audit data with 3 pages of things that could have gone horribly wrong, you know, that is kind of powerful. So it makes it real, it makes it immediate, and you can immediately then contrast the cost, just the financial, just the bald, stark, nasty financial transaction now of what is the cost of an adverse event in dollars versus the cost of signing up to this thing in a very small amount of dollars. And it's, of course, a complete no-brainer. And there's positive spins on that as well, because there's costs that you can save from saving a night in ICU. If you shave 1 or 2 nights off ICU stays for even 5% of your patients, you've more than made back the money that you've paid for the QI. So even small differences can make a huge cost saving for the organisation. We've mentioned this already, and if you really should get hold of a copy of this. It's a UK report, but it is extraordinarily uncomfortable reading. You've seen some of the figures from it already. This is a national report, 3 months of every tracheostomy in the UK. But it will be familiar to you in any other healthcare environment. You'll look at that and say, that's us as well. That could happen in my hospital. And like I say, it is extremely uncomfortable reading. Show that to your hospital managers, and they probably won't sleep at night. They'll certainly want to pay. And it may be at the start, if you're getting some pushback from management on paying the money, it may be that you need to demonstrate some commitment yourselves. I had to do that. I had to put some money up from my own departmental discretionary funds, and the hospital then agreed to match those and then pay all the fees going forward. So I paid up some money, and the hospital then said, well, this guy's committed, we'll pay from there. It may be that you can get some grants. Certainly in the UK, there are grants available for quality improvement projects on a regional level, so you may be able to find that out. Your management may actually know more about that than you do, so go and speak to them about it. And at the end of the day, if you need to put on a pink gorilla suit and run a marathon to raise the money to pay your first year's fees, to demonstrate to the hospital that they should be paying them thereafter, then, you know, crack on, I'll sign your sponsorship form. All right? So that's all I was going to say. I think we're ready for a tea break, are we not? Great. Thank you very much.
Thank you very much. Just some very brief housekeeping before we move off to morning tea. If some of you are feeling particularly enthused and inspired after that presentation and you wish to sign up your hospital right now, there are activation packs available at the desk, so feel free to avail yourself of those. Secondly, we've got the generous support of a number of sponsors from our colleagues in trade, and I would encourage you to engage with them. Without the support, events such as the symposium are very difficult to convene, so please support them as they're supporting us. There are a range of posters outside, which I'd also encourage you to interact with. And finally, for our members of the GTC team, if you could meet briefly at the podium before heading out for a desperately needed tea and coffee, that would also be very helpful. Enjoy your break. And our speakers as well, please. Enjoy your break.